Happy Monday morning. So just to give you a little bit of background here, really my interest in doing this particular research looking at SCAD was the reality that we don't have a lot of research overall with SCAD. And in general, the research that has been done has been either expert opinion or small trials, largely at academic centers that perhaps don't have the same community representation that our academic center does. What we know now and what's helped guide the current treatment of our SCAD patients is that after an event, standards of evidence-based medicine include the use of aspirin, beta blockers, Plavix, if a patient is hypertensive, either using an ACE inhibitor or an angiotensin receptor blocker, imaging the head, neck, chest, abdomen, and pelvis to find out if there's any other ongoing connective tissues issue or fibromuscular dysplasia, et cetera, and cardiac rehab that is specific to SCAD patients. We also know that this is a very unique population for our normal cardiovascular patients. They're often young, otherwise healthy women, and because of that, these standard of care that we recommend for many lifelong afterwards can be difficult from a quality of life and also physiologic reasons. So here we really wanted to look at not what people got prescribed, but what they were actually doing and why they may have stopped, what barriers were there. So thankfully, here at the Foundation, we have a large SCAD database that goes back to January 1st, 2005. So we did a retrospective review from January 1st to July 6th, 2020. And based on those both consensus and expert opinions, we looked at evidence-based medicine. If the patients were on all of those things, that was the end of their portion of the study. If they weren't, they got a phone call and the opportunity to participate in an interview about why treatment had been stopped or never completed. So here's what we found. Overall, 115 patients were looked at. The average age was 55. So while yes, it definitely, the mode is a younger age, the median in the patient population we had was 55. And so age 24 all the way up to 97. 97% of them were female. And you can see here 57% got medical treatments alone, 43% had a PCI, 4% had CABG, and 1 patient did in fact need a cardiac transplant. In terms of those that got that evidence-based standard, it was only 30%, so quite low when we look at about a third of all patients were meeting evidence-based standards. And then breaking that down, about 41% had gotten imaging of their head, neck, chest, abdomen, pelvis, 83% had been prescribed Plavix, 63% had been put on a beta blocker, were still on a beta blocker. 43% were on an ACE or ARB if they were hypertensive. 88% were still on aspirin. And about 56% had attended cardiac rehab. And what's interesting here, the first couple of points is, I didn't ask in the interviews that I was doing about misdiagnosis or mental health resources. That wasn't part of the goal, but overwhelmingly, that was what patients wanted to talk about on the phone. Their frustration that with being misdiagnosed, and I'm sure many of you have heard that story, that frustration that they'd been to an outside institution or emergency room first and people didn't know what this was. And then ultimately, the confusion that it took getting there. 37% reporting a lack of mental health resources, both during the acute event and afterwards. So again, overwhelming was the largest need they presented. 26% of folks didn't know that they should continue with a cardiologist long term. Interestingly, cardiac rehab, while it's not a surprise for many, I'm sure that this was driven by cost and availability. What folks brought up was if they had their event in the 3rd or 4th quarter of the year and needed to start a new cycle of cardiac rehab that required a new deductible, that was a big deterrent. And then the other piece was that a lot of places didn't have, they only had daytime hours. So for people who were working, that was an issue. And then finally, a lot of places didn't have access specifically to SCAD cardiac rehab or the education there. Beta blockers were discontinued often for fatigue and just overall feeling kind of lousy on those overall. Aspirin was a challenge for many, feeling like that was making their menstrual cycles heavier and that they were bruising easier. Vascular imaging wasn't really recommended until the last couple years in the database overall, and that's, sort of one of the concluding thoughts is that how we were looking at this over essentially 15 years, but how when knowledge changes in those 10 to 15 years, how do we get that disseminated more quickly? And then the other piece was for hypertensive patients, sometimes they weren't on ACEs or ARBs because they were on either calcium channel blockers or long-acting nitro for symptom relief instead. So, how does that get factored in? I think most of us feel like the symptoms of the patients are the most important thing, but when simply looking at evidence-based guidelines, they're not always on it then. So I guess in conclusion here, something for us to think about again. So what do we do with these folks long-term? How do we convince them that they're safe? And if we do, I'll believe that part of that has to do with evidence-based guidelines. Here we saw only about 30% of them met the evidence-based guidelines. And, understanding why that is, again, particularly in this unique patient population that's young, otherwise healthy, looking at quality of life, financial considerations is going to be a huge piece of that, and how we ultimately make sure that what the patient wants and needs as part of the ongoing solution will be something I think that we need to think about long term. And lastly, the point that we talked about, I think you hear sort of when a clinical trial comes out that the average dissemination time to actual practice is about 20 years. And I think that is going to be, and always has been, a question of how do we get that knowledge faster to places. How does a rural emergency room know about what the standards are for SCAD, or how we pick that up, or what imaging things we're doing, et cetera. So something to think about with all this technology and great stuff that we have. So thanks. Any questions? Good. I'm glad it was straightforward.
We'll entertain questions also at the end. Thank you, Courtney. That was very interesting, and I am sure it will be a popular abstract. Well done.
Thank you.
Can I call to the floor our resident badger? Chris Gitter from the University of Wisconsin, and joined us in 2019 as an intern, and then was selected as the lead intern in 2020 because of his intellect and his work ethic. He has subsequently graduated from the University of Wisconsin with a degree in pharmacology and toxicology, and he will depart us for University of Wisconsin Medical School this summer. Yeah.
Medical College of Wisconsin.
Excuse me, that's a major mistake. Thank you. And Chris is Chris has been working in the structural heart program, but also with Dr. Hauser and Sen Gupta on defibrillator and pacemaker issues regarding quality. And he's going to speak to us on matching implantable defibrillator longevity with patient survival, the clinical and economic significance of new battery technology. So welcome, Chris. Thanks.
Thank you, Dr. Sharkey, for that very warm introduction. Yes, the Medical College of Wisconsin, not UW School of Medicine Public Health, just down the road in Milwaukee. So yeah, I'm Chris Gitter. I'm a research associate with the Structural and Heart Valve Disease team, and I am presenting matching implantable defibrillator longevity with patient survival, clinical and economic significance of new battery technologies. So just a brief background. We looked at both ICDs and CRTDs in this study. We looked at single chamber and dual chamber ICDs, that's implantable cardioverter defibrillators, and we looked at biventricular ICDs as well, or CRTDs. And for all of these patients and for this longevity study, we wanted to look at expected normal battery depletion, or NBD. That's what we're looking at for the rest of the study, kind of freedom from the batteries depleting. It's important to remember when talking about ICDs and CRTDs that these pulse generators are both high power and high energy batteries compared to a lot of other medical devices. If you can match the overall longevity of your pulse generator to your patient survival, that's optimal. Being able to reduce the need to have a patient get another pulse generator in their lifetime reduces not only the clinical burden, I mean, the procedure has relatively low risk, but there are some risk of complications and also the economic burden to that patient and the healthcare system. In about 2008, companies started introducing a new battery technology, or a couple of different technologies, to try to combat the longevity issue. So the old battery technology was a lithium silver vanadium oxide battery, and depending on the company, there were a couple new battery philosophies, lithium manganese dioxide and a hybrid lithium silver vanadium oxide or carbon monofluoride. For us as presentation, it's just going to be new versus old, just for ease. This chart up here is going to show you kind of per company which different battery technology they went with. But the main thing to understand is, from a period from about 2008 to 2011, 2012, a bunch of new batteries were introduced. And ultimately, the study wanted to evaluate if these batteries were significantly better than the previous batteries. We had three main objectives for this study. First, we wanted to simply assess the longevities of the ICDs and CRTDs with these new batteries. We then wanted to compare them to the old batteries that had been around for a long time. And finally, we wanted to look at how these batteries matched patient survival, both from our experience here at MHI, and then we want to do an economic analysis based on how many replacements and complications that the new battery technology may reduce compared to the old battery technology. For our methods, we took all of the data for the devices from the publicly available product performance reports of 2019, and then we did Kaplan-Meier probability of normal battery depletion, NBD, for all those devices. For the patient side, we had a cohort of about 1,900 patients followed here at MHI from 2000 to 2010. And finally, we did a cost savings analysis to avoid replacements, procedures, and complications. In our overall view, we looked at over 1.7 million devices, so this is a very comprehensive survey of devices. We found that 42% of those were CRTDs, 35% of those were dual chamber ICDs, and 22% were single chamber ICDs. When you look at the new versus the old technology, about 22% of our devices had the old technology and 78% had the new technology. The rest of this here, for all these graphs, on the y-axis, you're going to see device survival, and that's basically freedom from normal battery depletion. And on the x-axis, you've got time in years. The red line here is the new technology, and the blue line is the old technology. If you can see stepping out in the years, so at about 5 years, there's 98% versus 85% new versus old. Going out to 7 years, at 74% versus 65%. And all the way out to 10 years, at 76% versus about a third. And this is significantly different. Next on this graph, the y-axis is going to be both device survival, and then we overlaid our total patient experience. So this is a Kaplan-Meier survival of those patients on the y-axis as well. Breaking it out per device, the dotted line is the old CRTD technology, and the solid line is a new technology. If you look at 6 years there, you can see 93% device survival versus 30% device survival. If we add in our dual chamber devices, again, dotted line is the old, solid is the new. Go out to 8 years, that's 96% versus 40%. And adding in our single chamber devices in red, dotted line is the old, solid is the new. Go out to 10 years, 97% device survival versus 50% device survival at 10 years. We then wanted to look and see how these new devices compared to our individual patient subsets. So all these dotted lines are the new battery technologies. Green is CRTD, blue is dual chamber ICD, and red is single chamber. First, we looked at an older subset, patients who are older than 75 years of age. We then overlaid our hereditary heart disease patients. So these hereditary heart disease patients are typically younger. As you can see, patient survival fairly closely matched the device longevity. Adding in the rest of our cohorts, we looked at dilated cardiomyopathy in the navy here, ischemic cardiomyopathy in the yellow, and patients with a reduced ejection fraction, less than 35%, in the royal blue here. And the main thing to take away from this is that, as you can see, these devices are closely matching our patients' longevity. And finally, here's a pretty simple graph to show something fairly complex in regards to the economic significance of these new battery technologies. So we did an overall cost savings analysis for the new batteries compared to the old batteries in terms of how many replacements and complications they prevented. So we assumed that each replacement would cost $50,000 and that 4% of those replacements would have complications, and those complications would have a cost of $60,000. If you look at it from a whole, there was a $10.8 million cost savings benefit for the CRT-D technology of new versus old. The dual chamber ICD at $7.8 million. And for the single chamber devices, that's $850,000. In conclusion, these new battery technologies can significantly extend the ICD and CRT-D pulse generator longevity, reduce replacements, and lower the overall costs and potential complications of those replacements and therapy. Going forward, what are the implications, or what's the future direction for this? So new CRT-Ds, as you saw, had marked longevity over the old CRT-Ds. When implanting a patient, that can be, sometimes be a debate between whether implanting a dual chamber versus a CRT-D. And as you saw from our review of 1.7 million devices, the new CRT-Ds have a marked benefit in longevity over those old CRT-Ds. And slowly we're reaching a point where some of these patients may only need one device for their lifetime. And that would be beneficial for the patient and for the healthcare system as a whole. That's all I have. Any questions?
We'll see if there's some more questions at the end, but I have to compliment you. That was an elegant piece of research and a lot of data that you presented. Have you written this up yet?
We have written up a different portion of that, so we are writing this up, but we did publish a paper in January with similar data.
Oh, congratulations. Thank you. Is that your mouth?
Yes.
Okay. Well, the next speaker doesn't really need any introduction, I don't think. Jesse Manunga is certainly known to all of us for his skill as a surgeon and for his humanity. And so he's going to speak to us here this morning on the impact of a multidisciplinary acute aortic dissection program, improved outcomes with a comprehensive initial surgical repair strategy. And just one note that I didn't know, that he has traveled to the Democratic Republic of Congo 3 different occasions to help them with their aortic surgery program. So welcome, Jesse. Thank you.
Thank you. Good morning. So today's talk is on the behalf of all my vascular surgery partners, all the cardiothoracic surgery partners, and cardiologists represented by Dr. Harris. As we all know, acute aortic dissection is a very high morbidity and has a very high morbidity and mortality. In fact, patients who survive index hospitalization have increased healthcare resource utilization. Traditionally, type A aortic dissection has been considered a surgical emergency treated with either an ascending aorta replacement or hemiarch. And type B aortic dissection has been treated with anti-impulse therapy. Certainly, this treatment modality makes sense, or philosophy makes sense in the short term. However, in the long term, a dissected aorta is prone to disease progression, aneurysmal degeneration, rupture, and in fact, 5-year mortality in patients with aortic dissection treated in this manner is about 30%, and long-term survival is less than 50%. The truth is, after dissection, a lot of these patients, if they live long enough, they'll require secondary intervention. The problem is that these interventions are very, very complicated because of no landing zone or the presence of a true and false lumen, which complicate both an open and endovascular intervention. Data published by Dr. Nienaber and colleague in Circulations about type B aortic dissection, asymptomatic, treated with TEVAR, made a lot of centers reconsider the way these patients have been treated, including our own. What you see on the left-hand side, on the your right-hand side is a patient who presented in late 2013 with a complicated type B aortic dissection. And we opted to treat the patient with a stent, and 6 months later, you see the drastic difference the stent graft made with the aorta completely remodeled. In 2014, the Division of Vascular Surgery got together, and after reviewing the literature, we decided whether we needed really to change the way we're treating patients with type B aortic dissection, and this included asymptomatic type B aortic dissection, and we picked a number of patients that we thought that will be undergoing endovascular intervention. We had some success, and the next year in 2015, along with Dr. Harris, we got together with all the cardiothoracic surgeons, every vascular surgeons. We asked ourselves, can we really apply this to type A aortic dissection? And really, credit goes to our CT surgeon led by Dr. Ben Sun and Dr. Moody, who's here. We accepted at a time that we would change the way type A aortic dissection is treated. What did those changes entail? They entail that vascular surgery will be involved in every type A aortic dissection treated here, MHI. And next, that will be offering a patient a more comprehensive repair, which meant either a hemi-arch or a total arch with a distal stent graft placement, a procedure known as a frozen elephant trunk. The hope was that in so doing, we will remodel the distal aorta and then facilitate future endovascular intervention should patient need them. These are some of the intraoperative pictures that we take during these procedures. You can see we're looking for malperfusion of either the SMA, the celiac, the renal arteries, and lower extremities. These are some of the follow-up CT scans showing how the aorta is remodeled, although I'm going to just skip them for the time being for an interest of time. The aim of this study was really to look at the data that Dr. Harris has been collected for many, many years and compare, see if what impact the changes to our program made. The study is a retrospective analysis of prospectively maintained data of all aortic dissections treated at MHI between the years 2003 and 2020. Patients were placed into two groups, pre-2015 and post-2015. Data collected included patients' characteristics, procedure metrics, and survival. There were a total of 323 type A aortic dissections. Sorry, I changed my slides a little bit. Pre-2015, we had a total of 210 aortic dissection patients at our institution, but not an insignificant number, about 113 aortic dissection patients were treated post-2015, with the majority in each group, as you can see, being type A aortic dissection. Looking at patients, breaking them down, type A and type B, compared to type A aortic dissection, patients with type A aortic dissection were significantly older. They had higher incidence of hypertension, and they had higher incidence of prior aortic dissection. If we break down patients in group of type A and type B aortic dissection and looking, was there any difference between the pre-2015 group and the post-2015 groups? There weren't that many differences. However, we do see that the rate of atherosclerosis was higher in the pre-2015 group compared to the post-2015 group in the type A dissection patients. And this is perhaps credit to everybody who's ever counseled a patient about tobacco cessation. We see that the rate of, there were a higher number of former smoker in the post-2015 group compared to the pre-2015 group. And focusing exclusively on type B aortic dissection, we see that the majority of patients with prior dissection were in the post-2015 group. Looking at the type of repair that's being offered pre-2015, many patients, about 15% of patients with type A aortic dissection actually were not given any surgical intervention. They were treated medically, and this number drastically decreased from 15% to 4%. Treatment modality of choice pre-2015 was really ascending aorta replacement, as you see here on your top right-hand corner, with 55% of the patients undergoing ascending aortic replacement alone. And this number drastically decreased in post-2015 to only 17%. The most common type of operation offered post-2015, this was offered in 78% of the patient, was either ascending aorta replacement plus arch replacement, so in the form of either an aggressive hemiarch or a frozen elephant trunk, as you see down here. Furthermore, there were more adjunct procedures offered to patients with type A aortic dissection in post-2015, including intravascular ultrasound, completion angiography, visceral artery stenting, and lower extremity fasciotomies. Focusing again on these patients, so when we're offering this complex operation, what is the complication rate overall? Well, you see that the rate of myocardial infarction, stroke, and spinal cord ischemia actually remain the same. In fact, the only difference that we saw is mortality, which decreased from 32% in the pre-2015 group to 10% in the post-2015 group. As we offer these patients a more complex operation, obviously, the length of stay also increased from 9 days in the pre-2015 group to 11 days in the post-2015 group. Looking at type B aortic dissection, we see that we're more likely to offer patient TEVAR, or thoracic stenting, intravascular ultrasound, and completion angiography. However, these numbers did not reach statistical significance, I think just due to the small sample size. Looking at the program as a whole, mortality decreased from 26% in the pre-2015 group to 10% in the post-2015 group, and this is all comers, type A and type B aortic dissection. Yet, again, this huge credit to our CT surgery friends. The biggest impact in mortality was seen in type A aortic dissection group, where it went from 32% to 10%. In conclusion, a multidisciplinary approach to a more comprehensive initial surgical strategy in the management of complex acute aortic dissection resulted in drastic decrease in 30-day mortality from 26% to 10%. We've seen it that the aorta remodel quite nicely when this procedure is offered to patient, and we're very hopeful that this will facilitate any future endovascular intervention. Yet the long-term impact really of these changes remains unknown, but we're hopeful that these patients will live a lot longer than they used to live. Thank you again on the behalf of all my partners.
Thank you. That was a great talk. And a couple of questions, if I might. Do you have any sense for why before 2015 the conservative management of type A was?
Yeah, I do. I think, as surgeon, really we give patients choice, but we can steer patient whichever direction we want them to go, right? We all know that. And really, this credit to Dr. Moody, who devoted a lot of his time really going around learning how these patients are treated at other centers after we had the meeting. Credit to Dr. Ben's son. They've been very aggressive. And not only are they on call, when they're on call to take care of these patients, but they're willing to come in when they're not on call and help their partners who are not comfortable with this type of operation. So I think that's one of the reasons is that people are more familiar, the people who have a lot of interest with this type of repair.
Then the numbers that we have at this institution, how do they compare with the other institutions you had up there?
Yeah. So as you know, as you see, Dr. Harris is in charge of the IRAD. We are one of the two hospitals in Minnesota that participate in this international body, with the Mayo Clinic being the other one. Our numbers are not, if you look at IRAD across the board, our numbers are just right in the middle of the pack.
Okay. I thought they would have been higher, but thank you. Great. I hope you write that up.
We have written it up, and it's been provisionally accepted pending minor revision. So.
Oh, congratulations. That's great to hear. Ross, add that to the list. Okay. Well, our next two speakers are Greek scholars, and this is kind of a bittersweet moment because Ilias and Evie will be leaving at the end of the month for Yale University internal medicine residency and ultimately cardiology, we hope. They've both been here since 2019 as part of Manos's complex coronary artery program, and I think they've added so much to our program, not only with their work ethic and their personality and their intelligence, but they took a trip up to Duluth, Minnesota the week of the polar vortex, courtesy of Christian Schmidt, and I don't know how else you can top that. So I'm going to introduce Ilias first. Ilias joined us in July of 2019. He's a graduate in 2017 of the National and Kapodistrian University of Athens. Did I do okay? He is also one of the 10 recipients of the World Hellenic Biomedical Association and the Stavros Niarchos Foundation Research Training Program, as is Evie. And Ilias's work with Manos's guidance has been on bifurcation lesions, chronic total occlusions, bypass grafts, outcomes after myocardial infarction, access to cardiac catheterization, radiation safety, and novel technologies in this field. And he will be pursuing, as I told you, career starting at Yale with a goal of becoming a cardiologist and continuing his research. And he's going to give us 2 talks. The first will be ST segment elevation, myocardial infarction in the young and very young patients, like myself, incidence and outcomes from the Midwest STEMI Consortium. And then his second talk will be treatment patterns and outcomes of bifurcation lesions, first results from the Prospective Global Registry for the study of bifurcation lesion interventions, or PROGRESS-BIFURCATION. Ilias, thank you.
Thank you so much, Dr. Sharkey, for the introduction. And as you said, the research fellowship here comes to an end in about 2 weeks, and we'd like to thank everybody here at the foundation and also the practice for the supportive environment for research and also for the mentorship that they provided. I have 2 talks, as you said. The first one is from the Midwest STEMI Consortium, where we looked at characteristics and outcomes of patients that are young and very young. And by young, we say 40 to 50, and by very young, less than 40 years old. And there have been data from the Harvard Partners Young MI registry that the share of young and very young patients is increasing among all patients with an MI. And young patients have similar survival to very young patients, even though the very young are about 10 years younger. And that's why we compared characteristics and outcomes between very young and young patients here at the Midwest STEMI Consortium Registry, which involves more than 15,000 patients with STEMI. And what we saw is that very young patients represent about 5 out of 100, and young patients represent about 15 out of 100 STEMI patients. And the rate, the share among all STEMI patients in our cohort has been decreasing during the past 18 years. As far as patient characteristics are concerned, the young patients have worse classical traditional risk factors, and the very young patients have higher drug use rates. There was similar peak troponin among the 2 groups. And upon discharge, we looked at secondary prevention measures, and the very young patients had lower rates of receival of any secondary prevention medication, as well as cardiac rehabilitation referral. And the 5-year survival, the long-term outcomes were similar between the 2 groups in the Kaplan-Meier analysis. And when we looked at what could influence that, we saw that only receipt of secondary prevention medications and cardiac rehab was associated with survival, and in fact with higher survival. As a limitation, it was a retrospective analysis. Of course, the data are prospectively collected, and it's a very comprehensive database, but as a retrospective analysis, we may not have all the parameters associated with the outcome to study. And as a conclusion, among all STEMI patients, the share of young and very young patients has decreased over the past 18 years, but very young STEMI patients have similar risk factor profile and mortality as young patients and are less likely to receive secondary prevention measures upon discharge from the hospital. The second talk is from the PROGRESS-BIFURCATION registry. That is a new registry from the Center for Coronary Artery Disease, This is also going to be presented at the ACC this year. This is about treatment patterns and outcomes of bifurcation lesions. This is a bifurcation lesion up here. Usually it is treated with one stent, but it can also be treated with two stents and with various techniques. And still, the best technique to use in each patient is not yet known. And there are many techniques that involve many different steps. They're very complex. Here is a video from Dr. Bilax's channel describing the 17 steps of the DK crash bifurcation technique. And also, bifurcation PCI is associated with adverse outcomes. This is our recent analysis. It's going to be published soon. And it shows that basically when we compare bifurcation PCI to all other complex PCIs here at MHI, bifurcations are associated with high rates of dissection. So that is why this registry was formed, to examine characteristics and outcomes of bifurcation PCI. At first, we looked at our center, all bifurcation lesions between 2014 and 2019. And the bifurcation side branch was defined as a side branch with a diameter of 1.5 millimeter or more. And we did a review of characteristics, the angiogram review, and also review of the outcomes of the patients. Primary endpoint was technical success. The definition is different when side branch stenting is attempted versus not attempted. And we also looked at the in-hospital MACE and follow-up MACE at 5 years. And up to now, we have examined 251 patients with 285 lesions, and with a mean age of 65 years. 7 out of 10 are men, and 14% involve a left main bifurcation. Half of them come due to and receive PCI due to an acute coronary syndrome. And in about 1 of 10 patients, more than one bifurcation PCI takes place during the same procedure. For the lesion characteristics, a true bifurcation is present in 60% of the cases, and a true bifurcation is defined as a bifurcation involving both the main vessel and the side branch. And 6 out of 10 main vessels are severely calcified, 4 out of 10 side branches are severely calcified. The first stenting strategy is most commonly the provisional stenting followed by the DK crash. The DK crash was the most common among the 2 stent strategies. And the same pattern follows in the successful stenting strategy, with the provisional being the most common one. So why do the operators choose an upfront two-stent strategy to begin with? Most commonly, they do it due to the Medina classification that we saw right before the previous slide. And also, a common tool of choice is the side branch diameter stenosis and also the angle. And there are challenges among the provisional and the two-stent cases. So 1/3 of the provisional cases involves a challenge in side branch rewiring or balloon delivery, and more than half of DK crash cases involve such a challenge. Technical success is high, is more than 94%, and procedural success was 90%, with around 6% MACE rate in hospital. And when we look at the 5-year MACE rate, which is death and TVR, we are looking at a 27% rate at 5 years. So in conclusion, bifurcation PCI is challenging and is associated with a high risk of subsequent MACE events. Thanks a lot for your attention.
Thank you. I see that your second paper is provisionally accepted at CCI, is that right?
It hasn't been written yet as a paper.
Oh, okay.
So this one.
All right. What do you think explains it looked to me on your first paper that the
Yes.
rate of myocardial infarction in the young and very young was dropping. What do you think is going on? Is that what it showed?
Yeah,
And why?
I mean, this is contrary to the previous findings, probably, because the study that I showed first said that basically the rate is going up among 40 to 50-year-olds. But the only difference I can find is that it's a STEMI here versus it's an MI in the other studies. So it involves non-STEMI as well, which may have some different risk factors, but really we don't have the data for that.
Smoking wasn't a factor.
We can look at that, and if like smoking decreased over the years, and that is why maybe STEMI rates were lower, but right now I don't have the answer, to be honest.
Okay, thank you.
Thank you.
Any other questions for Ilias? Mm-hmm.
Yeah, so we didn't do this analysis to present it here. I think by looking at the data, it's probably roughly equal. But that's exploratory, so we haven't explicitly looked at that as a separate analysis, but that's my sense of the data right now. Thanks.
Thanks, Ilias. Very nice. And I will ask Evie to join me, if I could. Like Ilias, Evie came to us in July of 2019, and she was also born and raised in native of Greece. And she has her MD degree from the University of Athens. And she also has had a 3-month Stavros Niarchos Foundation Research Training Award. Congratulations for that. Nice award. She's worked with us on X-ray optimization, I think reducing X-ray doses, and optimization in the cath lab, and research also with Manos on chronic total occlusions, bifurcation lesions, radiation safety. She, with Ilias, will be starting her internal medicine residency at Yale. It doesn't say cardiology. Is that on the list or not? Okay, thank you. So, Evie has 2 talks as well. The first one she worked with me on is entitled, "Is it safe to discharge patients with Takotsubo cardiomyopathy who have a long QTC interval?" And her second was with Manos on chronic total occlusion, percutaneous coronary intervention during COVID-19, insights from the PROGRESS CTO registry. Evie?
Can you hear me? Yes. So hello everyone, my name is Evie Vemu. I have been working as a research scholar at the Center for Coronary Artery Disease for the past 2 years. We are flying to Greece next Friday, so this is like my last talk here. I'm very grateful for all the mentorship and support from MHIF staff and MHI physicians and Alina personnel. So the first presentation I will do today is about chronic total occlusion and percutaneous coronary intervention during COVID-19 pandemic. So CTOs, or chronic total occlusions, are defined as coronary lesions with TIMI grade 0 flow of at least 3 months duration. Here we can see a chronic total occlusion before PCI. We can't really see the lesion, but after successful PCI, we can see the RCA there. So in order to ask the question if and how the pandemic has impacted the CTO PCI volumes and outcomes, we analyzed the clinical, angiographic, and procedural characteristics of more than 2,700 CTO PCIs performed on more than 2,700 patients enrolled in the PROGRESS CTO registry at 21 US and international centers. We compared 2020 versus 2019, and we only included cases from centers that had enrolled patients during both years of the study. What we found was that there was a 37.1 decrease in procedural volumes between 2019 and 2020, and as we can see, almost all centers, but 3, I believe, were observing this decline. The three centers that did not observe a decline in procedures were, 2 of them were located in the US and 1 was international. We found that there were some differences in baseline characteristics. Patients had more dyslipidemia, hypertension, and heart failure, and were more likely to be on dialysis in 2020. And also the mean JCTO score in 2020 was higher. JCTO score is a score that lets the operator know how easy it will be to cross the lesion within 30 minutes. And this was higher in 2020 versus 2019. Regarding outcomes, we found that although technical and procedural success rates remained stable, in-hospital MACE rates increased in 2020, and that was driven mainly by myocardial infarction, re-PCI, and re-CABG. Of course, this is an observational study, and with all inherent limitations, we only looked at in-hospital outcomes without long-term follow-up. There was no clinical event adjudication by a clinical events committee, and all procedures were performed at high-volume experienced PCI centers, thus limiting the generalizability of our findings to centers with limited CTO-PCI experience. So in conclusion, the volume of CTO-PCI significantly decreased during COVID-19 pandemic, 37.1%, and technical and procedural success rates remained stable. However, in-hospital MACE rates increased. The second question that we asked during this study was, is it safe to discharge patients with Takotsubo cardiomyopathy and long QTc interval? So as a background, Takotsubo in Japanese is octopus trapping pod, and this name is used because of the similar shape that the heart has during this condition at left ventriculography. Patients with Takotsubo cardiomyopathy typically experience electrocardiographic changes, including T-wave inversion and QTc lengthening over several days. QTc may be prolonged at hospital discharge, we know this, but its association with clinical outcomes remains unknown. So in order to answer that question, we analyzed the clinical characteristics and post-hospital discharge outcomes of 258 patients with Takotsubo cardiomyopathy between 2009 and 2019. We divided patients into 3 categories according to QTc interval at discharge. So QTc less than 460 milliseconds, QTc between 260 and 500, and QTc that was severely prolonged over 500 milliseconds. We only included patients that experienced an index event because there were also patients that experienced recurrent events in the study, and patients who died in hospital were excluded from our study. Here we can see the distribution of QTc at discharge. As we can see, more than the majority of patients had this prolonged QTc. Almost 1 out of 3 had the QTc between 460 milliseconds and 500 milliseconds, and 1 out of 4 had the QTc of more than 500 milliseconds. Regarding baseline differences and hospital outcomes, there was no difference in hypercholesterolemia, beta blocker use pre-admission, left ventricular ejection fraction presentation, ST segment elevation, and peak troponin. However, length of hospital stay was different among the 3 categories, with patients who had the highest discharge QTc having the shortest length of hospital stay. Here we can see the QTc distribution on admission, at discharge, and at follow-up. As we can see, QTc decreased significantly between hospital discharge from a median of 465 milliseconds to a median of 445 milliseconds. And at 1 year, there was no difference in mortality among the different QTc discharge categories. Here we present the patient that was included in our analysis. Although the initial ECG revealed a QTc of more than 500 milliseconds, and the discharge ECG also revealed a QTc of more than 500 milliseconds, the ECG of the same patients 2 years after the event was 467 milliseconds. Of course, it is a retrospective study with all inherent limitations, but in conclusion, we found that more than half of Takotsubo cardiomyopathy patients had prolonged QTc interval at discharge. At follow-up, QTc significantly decreased from a median of 465 to a median of 445 milliseconds. And despite the concern for Torsades de Pointes ventricular tachycardia, there were no sudden or cardiovascular deaths post-discharge in the group of patients with prolonged QTC at discharge. Post-discharge mortality at 1 year was not significantly different in those with and without prolonged QTC. Thank you very much.
Any questions for Evie? Jen, do we have any questions from the? Okay. Any questions for any of the other speakers that we have here this morning?
Actually, I do have one.
Okay.
Dr. Chavez. Any data regarding recurrent stress cardiomyopathy and QTC?
We excluded patients that experienced recurrent events. We only included index events in our analysis. So I cannot answer that question, I'm sorry.
Well, good luck to each of you for the presentations that will be upcoming. So thanks for coming this morning.